We can have a robust discussion. Yeah. So what we're doing and Becky gotcha. And actually, this is good because you guys actually grow with each other. Perfect. Yeah, I think it is perfect. It worked out really well. We'll have Becky come back and talk to us about this project. She's short on staff right now. So probably won't. Very well. Right. How are you doing with your work? Well, this week has been insane. On Monday, it's interesting. 17 hospitals. This meeting was in Fort County. So that 8%. Tuesday was disaster preparedness. Not only that, all day Tuesday. Fire in the kitchen. Major earthquake. Fire in the kitchen.
How are you?
And then the night you have yeah. So, and yes, my
Your work? Okay. As my son's like, call Martin. Which Martin Sanchez? Right. It was the first option. I'm like, you can't really always get it.
So are you going to be up there during the presentation? Or are you going to be close by, or I'll be close by? I get there Q&A.
And the pretty simple. Yeah.
Just
yeah. It looks good.
Yeah. Found it anywhere close. Yeah. So soon after we
Why don't I get you started? All right, guys, let's jump in. Lauren, we have hallway, you don't let us people you want to review this instruction to the people on the phone, I may just call on you. Okay. Well, you don't need to. Just explain it there, and here's my review, and give a little context. Can we get started, folks? First of all, take your seat, but those of you in the back rows, if you wouldn't mind coming a little forward, that would be nice. It looks like we're going to have a few people either tardy or absent today, and it'd be nice if we weren't so spread out, since there is lots of room. So, welcome to the September meeting of the Greater Columbia ACH Leadership Council. And my name is Patrick Jones. I'm from Eastern Washington University. And before we do the introductions, and I think we're getting to know each other pretty well, I just wanted to point out that for me, this weekend and the next few days is Thanksgiving. 2 months early, and maybe you haven't thought about that, but my wife and I have adopted a girl from China, and so we've adopted the Chinese calendar as well. So we do a lot of Chinese New Year, and the second most important festival in the Chinese culture is this weekend, which is Moon Festival. Moon Festival is the harvest festival, and Moon Festival is a time when families come together, and of course, what we all do at our Thanksgiving, we eat. And the Chinese have this wonderful treat, which I didn't bring for you today, called moon cakes. And so moon cakes are kind of a pastry with lotus seed flour in the middle, and they're shaped like a moon, and they're pretty good. So wanted to say happy Thanksgiving from Chinese culture. Happy Moon Festival. And I don't know if the communities here, the Tri-Cities, have actually a festival that we do in Spokane, and it'll be on the Gonzaga campus, and there'll be lots of singing and dancing and eating mooncakes. Okay, so with that, why don't we just get started, starting with the back row of our folks in blue, and just introduce yourselves in a loud voice, in as loud a voice as you can, so the people on the phone can understand who's here, and we'll just go around that.
Hi, I'm Michelle Kelly. I'm here for Paso Fire Department.
Okay.
And here, I'm the community risk reduction person for Paso Fire Department.
All right, moving over this way. I guess we'll go to Miguel.
Miguel Martino is the head of healthcare.
And Dan.
Dan Ferguson, director of the Allied Health Center of Excellence, representing community colleges.
Caitlin Patrick with America Group.
Caleb.
Julie Groves with Transferring Asthma Together.
Okay.
Middleton, GCACH. Corey West, Southeast Washington Agency Long-Term Care. Nicole Austin, Benton Franklin County Medical Society. And Susan Campbell from CBC. Jean Burrow from the Family Violence Center.
Okay, we forgot the gentleman in yellow.
Oh.
I didn't forget. Merit Resource Services.
All right, thank you.
For the Prospect and Franklin Health.
Very accurate health officer, all on the
Jack Davies and Northwest Rural Health Network.
Okay.
Kevin Martin, Chickasaw Valley Healthcare.
Glenn Peralta, Greater Columbia ACH.
Ronnie Baxter, Lutheran Community Services.
Doug Eaton, I volunteer with Blue Mountain Heart.
Diane Costa, Jackson Neighborhood Health. Lisa Hassett, Reaction Neighborhood Health.
Rhonda Hoff, Yakima Neighborhood Health Services.
Jenna Shelton, Greater Columbia ACH.
Martin Sanchez, Greater Columbia ACH.
Diane Halo, Greater Columbia ACH. Becky Coleman, Greater Columbia ACH. Carol Windsor, Greater Columbia.
West Lucky, Greater Columbia.
And last but not least,
Greater Columbia.
So, yeah, we have two people. Luann, go on. Can't talk? Oh, sorry. Okay. Do I have this right? Luann Ayers from Ben Franklin United Way. Did I get that right? Okay. And then one more person. Okay, welcome. Now, Lauren, would you mind introducing yourself? And then before we get to people on the line, I just want to point out, for those of you on the line that have received the, and are looking at the meeting agenda, we have a little request for you on how we interact over the phone. So I'm going to let Lauren just touch on that very briefly so we can all understand each other a little better than we have over the past few meetings. So
it's been brought to our attention that people on the phone are having a hard time hearing due to an echo. So this meeting, we're going to try to put everyone on mute after attendance has been taken and see if that takes some of the echo away. If you could, please use the chat box if you have questions, and we'll make sure to refer to the chat box hopefully throughout the meeting, and we can address those questions.
all right. So thank you, Lauren. And with that, can we have those of you who have phoned in to introduce yourselves and then mute yourselves? Anybody on the phone?
Good morning. This is Elia Prostowski from the Olympic Community of Health.
All right. Hello, welcome.
Good morning. This is Kirk Williamson with the Benton Franklin Community Health Alliance.
Hi, Kirk. Anybody else?
So, Patrick, good morning.
Who was that? Was that Jorge? Welcome, Jorge.
You look to your left on the third row. I'm not there, so yes. First time in like a couple of years that I'm not personally.
Yeah, I think
I'm here.
You've broken your streak.
Yes,
Anybody else on the phone? 3 of you so far. Okay. So, as you'll see in your agendas, we'll start out just with our little business report from staff of the ACH, and who is going to cover that? Would that be Ms. Moser?
I guess that would be Jenna or Martine or Sam.
Yep, so I actually.
So would you mind coming up in front, please?
Sure.
And
So
speak close to that.
Yeah. For the month of August, that's the article, what that is about. Pretty much we've been traveling all over the 9 regions. Jenna and myself and Sam. Were you with us in the car in August? So Diane as well. We've been meeting with behavioral health agencies doing the MEHAP and billing toolkit assessments. And just kind of, forming our relationship. We've been to several places, several times, just follow-up meetings, see how things are going. We went to Bluemont Counseling, which is the pictures you guys see on the news article. They had a therapy cat named Stripe, so that was really cool to hang out with Stripe. So we had our meeting. And we've been meeting with primary care offices as well. Starting the kickoff meetings, we've done a couple patient-centered medical home assessments in Othello. We've done one. We're going to be in Pullman tomorrow. And then we're in Yakima. We've been to Walla Walla. We've been to neighborhood health this week. Earlier this week we were there. And going forward, we're still meeting with all the agencies we've been meeting and meeting new ones as well. We're starting to check off some of our items on our tracker that we have for each agency, which when we meet, we'll share with you guys. We have one just for your organization. Where as we work on this project, we'll be checking off boxes as we go along. So. That's it.
Okay, thank you for the report.
Yep.
Next.
Yep. Good morning. Okay, so the portal.
I think it'd be better for the people on the phone to come over here. Yeah.
You're driving the bus.
Okay, is this okay?
That's better.
Okay, all right, good morning. So the article in the, about the portal this month is about the BHO contracts that we're signing. There's 17 providers that we're working with, most of you know that. We've gotten 5 of the contracts signed, and 5 of them are being paid tomorrow. So they got paid $10,000 for completing their MEHAF and $10,000 for completing the billing toolkit. So we're really excited to get those payments out. They're in the portal, they'll be paid tomorrow. So good job, guys.
Okay.
Last, well, it just, who's
What-
gonna do the road show?
So Wes and I have been traveling to every local health improvement network and which we call it their Wes and Ruben Road Show. And the point of attending these meetings is to ensure that everybody has a good understanding of our selection process for practice transformation, the PCMH model. And what we did, we described the selection process and the rationale for doing practice transformation and for choosing the PCMH model for those ends and for that end. And that's pretty much it. We have, I think, 1 local health improvement network left to do. So we're almost done. So we've done. We haven't done as much traveling as Jenna and Matilda, but we are spreading the word. We're usually right behind them with our own little car with all the signage with Columbia, ACH. So also on the newsletter, we sent out some communication. There's a campaign that was put together by the Department of Health, a prescription opioid abuse awareness campaign that the Department of Health asked us to help launch a social media campaign. So we're asking all the links to participate in it. And it's a very, obviously it's one of our projects, the opioid crisis. So this will help tremendously for those purposes as well. So, Wes, anything you'd like to add?
No, it's been a great opportunity to meet with our local health improvement networks as we've gone across the region and talk about PCMH and some of the other activities that we're doing.
Hey, Miss Diane.
Overhead.
What happened there, Diane?
I broke my arm.
Oh, my goodness.
And
In
I
the office?
had surgery, no. I tripped and fell, of course. Okay, so for the behavioral health integrated managed care update, we've met actually, it says 14, but we actually have met with 16, and they have the other ones scheduled. So we're almost have met with all the providers. All the contracts are out, like she said, and so we're just moving right along with it. I think all the providers are in a really good spot. They're all getting ready for the transition. And the provider readiness meeting, we had a really big, successful one with the MCOs. We had an attendance of over 50 people, so it was really a good attendance for them. And then also I wanted to bring up, in the Integrated Managed Care Communications Work Group, we finalized 4 documents that will be sent out. I sent them out to the providers this morning so that they have them, so when there's a 90-day letter going out at the end of this month to the consumers, letting them know that the transition into managed care. And so we want to make sure that everybody has that communication so that they can help their consumers go through this process. So I'm going to also send them out to the health districts and some of the other agencies so that if any other consumers have any questions, that they come, these will help answer any of those questions. They're also going to be translated into Spanish as well. So as soon as I get the Spanish ones too, I'll distribute those as well. And that's pretty much it. Okay.
provider readiness work group, is that primarily the BHO provider?
Yes,
Yes,
yes.
that's part of IMC, Integrated Managed Care. So I'm Wes Leckey. There's a brief article here about one of the components of our HIT strategy. This is called direct secure messaging. This is something that sometimes comes with provider EMRs, and what it allows for is care coordination, transitioning of information, and it also allows for referrals to potentially social service organizations. So one of the big strategies that we want to do is to link not just our initial cohort of partnering providers, but other provider organizations to organizations that are tied to the social determinants of health. So this is one mechanism that we'll be using to carry that out. We received presentations from 3 vendors. One more vendor will show us a presentation, and then we're going to make a selection. There's other HIT strategies that we've talked about and we will be talking about today. Rob Arnold, who's joining us from Quading Partners, is going to talk about a really exciting pilot project that's happening in Ellensburg. Elia, who's the executive director for OCH on the phone, has been using Rob, and they've had great success with this work. It's exciting enough that it also might be something that we scale elsewhere throughout the ACH. So we'll be hearing more about that just coming up.
Thank you, Wes. And last but not least, Executive Director, Ms. Carol Moser.
So I guess I'm batting cleanup this morning. Unlike Wes, I have a really long article because it's about workforce issues. I was recently appointed to the state's Health Workforce Council, and I had my first meeting last Thursday. And what they wanted to hear about is, so within our region, how are we viewing workforce issues? And I have to say that it has taken a little bit of a turn with adoption of PCMH, which is really centered around team-based care. And I'm very excited that at our board meeting today, we'll be talking more about care coordination, because the missing link that we have within PCMH is how are we going then to contract with our care coordination partners, such as aging and long-term care, and our fire departments, and our EMS services, and our care coordination agencies. So I'm really looking forward to having that discussion with the board of directors. I'm not going to read all of the article to you, but it really highlights, there was some really great information that I found in an article about the difference between our current healthcare workforce and what the future looks like. Because really, when you're talking about value-based payments, which is the era that we're all being ushered into, it's going to be the quality of the care that will be rewarded, not the quantity. And so having this wraparound service for our high-risk, high-utilizing population, which is the target population that we have chosen, is going to be really influenced by who we bring to the table. So in a normal team-based care, or in a team-based care model, I wouldn't say normal because I don't know what that looks like. You would have, your primary care physician, your behavioral health specialist, you might have a nutritionist, you might have a pharmacist, you might have a community health worker, peer support, a licensed social worker. So as we're talking about this as ACHs, each one of us has a little bit different model of that team. Each organization has its own model of team-based care. So then the trick is, how do we pay for that? How do we reimburse our providers? So I think that as we move forward, we'll have a lot more information about how we can re-energize the workforce task force. I know, Angelina, you're on that, and Dan, because we're getting to the point now where we need to gather in these resources and address care coordination. So that's it.
Okay.
And I think Lawrence, maybe you're the batter.
We've got a few latecomers, so those of you who've chosen to sit in the back row, you get to introduce yourselves. So, Kat, we'll start with you and speak up, please.
Hi, everybody. Kat Latte, Community Health Plan of Washington. And I'm Natalie Christopherson. I'm the tribal liaison for Community Health Plan of Washington.
Thank you, Natalie.
Sandy Caroga with Coordinated Care.
Okay.
Angelina Thomas with Yakima Valley Farmers Clinic. Sandra Flores with Yakima Valley Farmers Clinic, and I also represent FKHP on the GCACH board.
Thank you. Yeah, I think we got it. And in the very back row in the corner there, Dr. Persa. Medical officer, yeah. Okay, so happy to see our invited guest speakers made it over the mountains.
I'm sorry, we forgot about the helper. Did you want to say that?
Oh, sorry, we got
That's
2 minutes.
my bad.
So, for the October Leadership Council meeting, we'll be hosting a health fair in place of Leadership Council meeting. It'll be on October 18th at United Way. We will be asking our CVOs to host tables at the health fair. More information will be coming on that. And then we're excited to announce we got another car. So now the West and Reuben Roadshow can use one car and the Navigators can use the other car. We haven't had too much overlap yet, but this week I know that there was one car that was in Pullman twice, and there's another one all over the place. So we're excited to have another car. It's blue, so if you see it, think about it.
All right. Tell us where it is in the parking lot so we can admire it.
You'll find it.
Okay. The other one's white, isn't it?
Silver.
Silver, okay. Okay, so today we're going to learn about 2 projects. Yes.
Is there a possibility of asking questions about what was presented?
Sure, yeah, quickly. Yeah, go ahead.
I have a question to follow up. I presume, but I have not actually seen it, that the ultimate goal of behavioral health providers is to provide what used to be called mental health services and was variously called substance abuse services, addiction services, chemical dependency services, and so forth. To provide those in an integrated manner in the same place by the same team of providers. Is that the goal?
I'll let somebody who's a little more up on this than I am. I think the quick and dirty answer is yes, but there's probably some nuances to it that I'd like somebody to weigh in on in this integration between behavioral and physical health.
Now, integration between behavioral and physical health, the integration of services within behavioral health from what used to be separate mental health services and
I see.
addiction
Substance
services.
abuse. I see what you're saying. Okay, gotcha. So we have a hand went up. Kat, real quickly.
I can help. I mean, I think ultimately the desire is to have an individual be able to have access to those services, and I'm going to include physical health, mental health, and substance use disorder services within that an accessible way. I think there's a desire to have people have embedded services, whether it be behavioral health services, including mental health and substance disorder services within a primary care setting and vice versa, or within a mental health setting having substance use disorder services present and vice versa. However, I think what we want to make sure of is that if you have a small SUD provider that doesn't see it as technically appropriate to have services all, come in and I mean, I think the idea is how do you have the best connections to the individuals that you're serving? And so how do you have the best referral patterns? How are you making relationships across those service providers so that, again, the individual that's being served, that you're serving, or that the provider is serving, has really access to all the services that that individual needs. But I don't think it necessarily means that everybody is going to be co-located in one location. Is that, I mean, so I think that sometimes that is a misperception when we talk about integration, but it really is that an individual has access to all those services in an integrated fashion that everyone's communicating and working together on a team. Doesn't mean people have to be face-to-face or in this integration.
I understand what you said, but you gave me much more information than I needed.
Okay.
The piece of information I needed is when we hear this is a behavioral health provider as one of many different kinds of provision of services, but when we hear that it's a behavioral health, does that mean that we can assume or can that they are working toward in the future being able to provide what used to be called mental health and substance abuse services in the same place with the same provider team?
Chuck, that may not always happen. That may not always happen.
Okay, I want to go to an expert here, Miguel. Do you want to talk about your experience?
Great, time out. Expertise is the burden of progress. However, what I can attest by is I do have experience working in several states. And every state in the nation has a different approach to integration, and everybody's in a different continuum to integration. The standards of integration are well delineated in our literature. So it depends upon who you're speaking of. Are you speaking of a provider? Are you speaking to an MCO or an insurance carrier? Everybody will have a very different definition of what integration is, depending upon their continuum and their primary business interest. Through integration, it speaks of licensed professionals capable of delivering the majority of services that somebody needs.
The majority.
The majority. There are certain exceptions. You know, there are certain specialties. You know, sex offenders is a specialty. Developmental disability is a specialty. Autism spectrum disorder is a specialty. Within certain specialties, through integration, it speaks of programs that are able to deliver the majority of services within one location. And then those other specialties, and then to have a strong either co-location or very strong hands-off referral system that can aid the client. So that is the ultimate goal. People might be at different stages of that goal, so that is not to minimize that we're all hoping to aim to a goal.
Okay.
I'll stop there.
Okay, thank you, Carla. Speak up.
For Chuck, hopefully this helps. If I am a layperson and I hear that this clinic offers behavioral health services, do I assume I can receive both mental health and substance use disorder services in that particular facility? Or is the phrase behavioral health, and that's how we're using it in our facility, so I'm glad you asked the question, a new nomenclature for either or both? So if I say behavioral health, could it be just a mental health services provider?
Yes.
Because that is the new structure at the state level, that we are, that the two systems are integrated at the state level. So we say the word behavioral health to reference either or both, but that doesn't mean that the individual provider will provide services that way.
Yes, they can refer, and if they don't have it integrated, they will refer and have somebody. Yes, yes.
Nevertheless, the true behavioral health definition, which has to progress significantly and it has evolved into it, started at the primary provider level, started at the primary clinic, because if there was no biological, there was a behavioral issue. So that's how the term behavioral health began to emerge. So behavioral health encompasses a lot more than just trying to coach somebody about the correct lifestyle changes that they need to do to mitigate the diabetes. Just that if a doctor practices from the biological model, and then the doctor has limited himself to his practice and says, hey, what I can do for you is to prescribe this pill that will help you manage your diabetes. Now, that is not the only solution. I'm going to have you speak to the behavioral health to see what other aids or what else can he or she brings to your picture for you to mitigate your diabetes. That's how that started. It has evolved tremendously, which I'm an advocate of that furthermore integration. I mean, once you arrive to a master's level and a license level, you're owed to perform counseling therapies in a wide array of competency. And in one sentence, you might be a coach in a facilitator of education, and in another sentence, you're owed to sit down with someone and do a different type of therapy and intervention, depending upon the setting. So I do caution us about just labeling things right or left that really have no meaning just for the flavor of the day. And I also beg you patience, because there's a lot of different professionals in this world, including MCO, insurance, medical providers, behavioral health people, and everybody has their own sort of a flavor to what that means. And there's literature that informs us what that is. So it doesn't matter in which side of the fence I'm sitting. If I'm told to aim for integration, it shouldn't be my own particular business definition. It should be what the literature already informs us and what my role in that is. I promise I'll be quiet the rest of the time.
Any last word from the ACH folks about how that's seen by the state of Washington? We're good?
Good.
Okay, so Rob, do you want to come on up? We're pleased to have two speakers from to start off today. As you see in your agenda from the west side, and they made it over the hill. No snowstorm. So welcome. You can, on the back page of your handout, you get a bio of Rob, and you can see that Rob has been quite the entrepreneur in the space of health IT, and currently he's CEO of Quad Aim Partners and very involved in the project that you're going to hear about, the Health Commons. He's brought a colleague of his, and it's Adam, Adam Davis, and you've also been involved in the Healthcare Commons or Health Project?
Yeah, so I'm a
Commons Project.
Family nurse practitioner and psychiatric nurse practitioner by trade. I work with fire department in South King County called Puget Sound Fire.
All right, so you guys have about 40, 45 minutes, and then we'll have time for Q&A.
Perfect. And Dr. Martin's going to join this discussion too, since he's
Imagine my surprise.
Yeah.
You just can't leave the stage here, Kevin. Okay, I'll let you guys go to it.
Okay, thank you.
Requested that we use the mic on the
Great,
phone.
and we do actually have Elia from Olympic Communities of Health on the line too, and this is where this original idea, this particular project has many parents. So Elia was one of the first folks to really understand and embrace this idea. You guys want to? So I'm not going to follow the slides specifically because you'll have a chance to read the slides at your leisure or whatever, but there's really just kind of four things we were going to cover. One is a little bit of the history of this project, and then have Kevin talk a little bit about the work that's already being taken place in Kittitas, and then Elia and Adam will spend a few minutes talking about their work in South King County and Olympic Peninsula, and then we can kind of follow up with some questions, and maybe Carol and Wes want to say a few things about it too, because they were certainly the initial champions for Greater Columbia. Just as a quick backgrounder on what this project is and where it originated. After my last company, I took up a position at University of Washington called Executive in Residence, and the specialty was around healthcare innovation advisory. So it was kind of a fun title because it didn't have any responsibilities to it. So it was a chance to kind of think openly and work with the health system at UW, but also communicate and collaborate with members of Governor Inslee's office and the Healthcare Authority. So it was Dr. Bob Crittenden. I don't know if many of you know Dr. Bob, but was just a great partner, collaborator, and Dr. Dan Lessler were the first two that, as I took up this appointment at UW, I went to Dr. Bob and Dr. Dan, and I said, what's your big challenge? You know, if we're going to do something with technology or innovation, you know, what's the problem space that makes the most sense? And your conversation prior to this was exceptional, by the way. Thank you for opening up those types of conversations, because they did say behavioral health and being able to figure out, you know, how to, and it wasn't, you're the practitioners and providers and experts in behavioral health. I'm a software guy, so I don't know what you do. I just have great respect for what you do. But the challenge that was put to me was along the lines of what you were discussing, which was the flow of information. How do we get information from A to B to C to D to E to F, and make sure that, because there are so many subspecialties in each area, whether it's primary care, behavioral health, or other subspecialties, flow of information between non-related agencies. And what I mean by that are people that might be physically located in different places, and people that might be working in different practice settings, and you might have, you know, a housing issue or a substance use disorder issue or a transportation issue and so forth. And so the question kept coming back is, we have individuals in high needs and complex situations, and there's a continuum of care that's needed to support them, and not all the care can be provided by a single person, and not all the services can be delivered. So how do you start to organize what we've termed, and it was actually Elia, if Elia wants to share credit with somebody else, but I first heard the term from Elia, a natural community of care. So the way I interpret that is essentially there's a set of care services and there's a set of experts around those care services. And there will be different transitions between these different individuals, so far as not only the individual patient care and the services that are coordinated around that individual, but where I specialize is really the flow of information. So what you do is super, super difficult, and I have great respect for how difficult that work is, because how to pass information between each other, and I learned this in working with Ellie and team in Olympic, is that most of it is done by phone calls and fax machines. That's the state of the art. And the next state of the art is we're going to use our EMR to send faxes. And I'm like, oh my God, this was horrifying to me, because again, I come from a different world, and I'm like, there's different ways to think about this problem and really come up with tools to be able to do this. And so I'm a software person, a software developer, and so, but I also know I don't want to immediately run out and build software, because it can be very complicated to now try to figure out new models of being able to do this. And so what we came up with this idea, and there's a website called healthcommonsproject.org, and you'll see it in some of the slides and stuff. But this is a model, if you will, that really talks about what are some of the practices to be able to help set up and organize a natural community of care. So how do you start to figure out what are bundled services, and eventually things like value-based payments and so forth, where you're starting to look at, more of how do we make sure we put somebody on the right track and improve their world, their life, but also make sure that you're able to get payments around that, but the information flow. So how do you do this, and how do you, if we were running a relay race, how would you pass the baton to the next person to make sure they don't lose speed and can pick the baton and run?
I'm actually going to challenge one thing you said, which is the real state of the art. You're right, the state of the art is still phone calls and fax machines. But the luxury item, if you will, is face-to-face contact.
Yeah.
And that will still be the case when we come up with something digital, but it's a luxury that few of us can afford. It's kind of like saying the state of the art in air travel is a 737, but if you've got the money, you can have a nice private jet. Most of us will never see the jet. Most of this will not be face-to-face.
Yeah, and
Sadly.
Such an important point, and this is something Adam and I were chatting about this on the way over, is that, when we see information today, if it's on a fax or whatever, it doesn't tell a story. It doesn't come alive. We don't really know much about this individual. We see a diagnosis code, but we're really not getting a picture of who this person is. And so, thanks, Dr. Martin, because we really not only trying to figure out how to make that information come alive, but also how do you provide, if you're physically located in different places, how can you still use information to coordinate in the ways you work? So make a long story short here, healthcommonsproject.org is kind of a description of what this program is, but in essence, it's a support system to be able to form these natural communities of care. And once we know the care types and care services and the things you want to do, then we also add in this thing called the Commons Network to make sure the information to help you deliver this care flows with you. And so take it one step technically deeper, we want to make sure that you're using the tools that you use today so it doesn't break your workflow and all this other stuff. And so the concept behind the system, it's not a lot different than like an airline reservation system or something like that. But in essence, it's a referral network that we're able to track the states and the statuses of referrals. And what I mean by that is when you send a fax today or you send information, you've got a sender and you've got a receiver of information, but you really don't know what happened. So did the person make the appointment? Did you have transportation to get to the appointment? Did you get partial information? Did you get, were you still looking for information? So you still have all these back and forth. And so the system that we've kind of laid out is an actual electronic referral system, meaning you're getting more complete information and you have the ability to send a referral, you have the ability to accept a referral, if you want to ask for more information, but you can now do these things in an electronic format, so you can get very deep and very granular. And you're going to get a sense from the community level, are we making progress with this particular individual? Did they get to the services that they need? What was the wait times? What was, in essence, it's starting to move the information electronic. And so that's a little bit of the background. And again, there's a little bit more history and kind of how we connected with Carolyn West. But we're doing a pilot project right now, and I'll let Dr. Martin tell you a little bit about the work that we're doing. But hopefully that background, I can pause there for a second. Hopefully the outline of what this thing is makes some sense. We can dive into lots and lots of technical detail on it, but it probably helps just to hear the use cases, because this is really what it's about.
So in Kittitas, our local network came about essentially out of community-based care coordination. And spontaneously, 3 years ago, there was a perceived crisis in the community. We thought we were losing half of our skilled nursing facility beds. One of our 2 buildings was closing. And the community perception was that the evil corporate ownership was withdrawing care from the county, and we were going to have to deal with 60 displaced residents, and where will they go? So aging and long-term care, the admissions coordinators from all 3 of our assisted livings and the remaining SNF, social work from the hospital, nursing from both KVH's Family Medicine Ellensburg Clinic and CHCW's Ellensburg Clinic. And forgetting somebody that was at those early meetings, came together and tried to come up with an action plan. What would we do with these 60 displaced people? The answer was nothing, because there weren't any. The reason they were closing one building was they had 2 buildings that were half full. They moved people from one half full building to the other half full building, problem solved. But in the process, those people that came to, KVFR community paramedics, good grief, we've been meeting in their firehouse for 3 years and I forget them. These people came together and discovered that, okay, that problem never really materialized. But just in sitting around, they realized that they were touching the same people. And when you were talking, what was the term you used? Unrelated agencies?
Or not related,
yeah. Yeah. We discovered quickly there's no such thing. We're all related because we're all touching the same people. And they found that there were particular people that the police and the fire department were interacting with in particular that none of the rest of us were seeing. And a lot of the reason that police and fire were going out was because none of the rest of us were seeing them. So we started, it became known as the A-Team. And over the course of 2 years, we've touched about 120 people. Interventions have ranged from a guy who KVFR made 15 runs for fall assist, transported to the ED once, so nobody in the quote-unquote system knew there was an issue. But a couple, 3 times a month, we were taking $1 million rig out of service for 45 minutes to help this guy up off the floor. Found out that his problem was that to get into his double wide, he had to go up 2 steps without a rail. And once he fell, he couldn't get up. He could crawl inside and call for help. We built him a ramp. He stopped calling. Another individual was calling 911 6 times a week. Once early on Monday, late on Monday, early on Wednesday, late on Wednesday, early on Friday, late on Friday. He couldn't get to dialysis. We arranged transportation. Transportation couldn't go in the house to get him, and he had a wheelchair and stairs. Built another ramp. Paramedic knows what his dialysis schedule is, goes out, gets him in the chair, gets him to the doorstep. Hope Source comes, gives him a ride. They put him back in the van when he's done. They get him home. we stopped getting calls. Some of them were resolved by referrals to hospice. At the other extreme, there's one individual that we've been interacting with for 3 years, and the most recent intervention was the appointment of a guardian ad litem, because really what we're responding to is the fact that she won't make safe decisions, but doesn't rise to the level where designated crisis providers can say that she needs to be committed against her will for her own safety. So we've got a guardian, and we're trying to get to where we can do that. So the goal of the group was, once we realized the power of what had come out of nothing, was to be able to do more, to be able to identify people before they fell into the safety net and respond to them by some combination of community-based nurse practitioners, community paramedics, health workers, social workers, but basically meeting, deciding what they needed in a coordinated fashion and deploying those resources. Well, in order to do that, we have to have A, tools to identify them, and B, a way to communicate their needs and what the responses were to interventions, and capture that data so that we can analyze it at a systems level and look, A, prove that what we're doing is working, B, figure out how to make it better, and C, make sure that we don't lose track of anybody. And that's really where the comments came in. So we started with a simple use case. When we looked at the 18 data, we found that the most straightforward people we dealt with, we had a very bimodal distribution in those 120 people we dealt with. The majority of them we would discuss 2 or 3 times, and they wouldn't need further intervention. And the common thread with those folks was a mental health diagnosis. And we could, if they were Medicaid, we get them connected with Comprehensive, and Comprehensive would do a good job of keeping them out of the net. The other population is more like the last case I described, the individual who stubbornly clings to their autonomy, and where our stated goal is to protect their autonomy, but is making decisions that are blatantly unsafe. One of our more spectacular failures was an individual who chose to live in the home that they had started building for their child, which at that point was a half-buried shipping container that was infested with at least 3 species of rodents. And we didn't get the individual out before a wound got infected, and we lost a leg. So we look at that, and we couldn't compel a safe choice. And there was we felt helpless. And we need to be able to mobilize tools so that we can get in and intervene. So that's the use case that we're working towards, is how to mobilize multiple sources over the long term. But the simple proof of concept case will be mocking a referral from the emergency room at the hospital to Comprehensive to prove that the engine works. And then we start adding points of entry.
Absolutely. And, as Dr. Martin said, when you start with looking at who is this individual and what are their
Roger,
needs.
did you use the mic?
Oh, sorry. I was going to say, as Dr. Martin said, when you start with the individual and you start to look at the person and you start to understand more of what that person needs, that starts to open up what are the care pathways. And so the model behind it is, again, I'm all the way down in the how do we make information flow, but again, it's all your hard work that is actually the outreach to the individual and how you organize and how you communicate. What I can tell you is that from a technical standpoint, we can do better for you than what's available today. And that's where I want to continue to prioritize my time on that side. So, Elia, I don't know if we can put the phone up to, or if we're going to be able to get Elia to, we'll come through for you. Okay. Elia, would you mind sharing a little bit on Olympic and the work up there?
Yeah, no problem. I'm unmuted. So, can you all hear me okay?
Yeah.
Okay, great. Well, good morning, everybody. I'm Elia Krastowski. I'm the Executive Director of the Olympic Community of Health. We're the ACH in Clallam, Jefferson, and Kitsap counties up here on the northern part of the Olympic Peninsula. And I started working with Rob about a year ago when we were identifying issues of health information exchange between behavioral health providers and primary care. And some of you may know that we have been working on an opioid response project up here for about 2 years now. And we really wanted to do was just allow information to flow from a primary care provider who is providing medication-assisted treatment to a substance use disorder treatment provider who was providing wraparound SUD services, so that referrals can flow back and forth and they could provide whole person care for people with opioid use disorder. There was a concern among the primary care providers 2 years ago that if they started getting their buprenorphine license, their license to prescribe medication-assisted treatment, that they would have no community support and it would be overwhelming. So this was an attempt to better connect SUD with primary care to provide more whole person care and kind of spread the time intensity of treating people with this condition. So we started, about a year ago, and we've set up a use case in Clallam County, and information is flowing between SUD and primary care at this time. I don't think any real patients have been going back and forth yet, but they've been the frontline providers from SUD and the frontline providers from primary care have been working really closely, and it's been kind of fun to watch them identify differences in their language and coming up with forms and formats and communications that were usable on either side and made sense, fit with the respective EHRs, and also were compliant with 42 CFR Part 2. So there's just been a lot of learning on either side. It's been pretty fun to watch, and we're really excited about this. It's been a lot of work getting it set up, and we're really hoping for a partnership with other ACHs and with Puget Sound Fire to share the various use cases and programs and computing efficiencies, because we are also really interested in community paramedicine in our region, which I think you'll hear from Adam in a little bit, and very interested in kind of the social determinants of health use cases that we just heard the previous speaker talk about. So instead of us recreating the wheel, we would essentially kind of draw down from what you learn and your toolkit, if you will, and just apply that in our region. And we, of course, would offer to the Greater Columbia providers everything we learn from our region around SUD and primary care use case work. So I'll stop there and see if there are any questions, or Rob, if there's anything important that I missed.
No, that's great, Elia. We've got Adam here as well, so maybe Adam, you can talk about your work in South King County.
Great. So I get to represent both Puget Sound Fire and Valley Medical Center here today. We've, for the last 5 years, been working on a program very similar to the work going on in Kittitas. It's a community paramedicine program called FD Cares, and very similar stories. We go out and we identify high-risk, high-need populations and try and connect them to care, get a 360 assessment of what's going on in the home, with the family, in the community, and see if we can better connect them into the system. What we've learned is that there's a lot of people in our community who are working together to provide care for these individuals. In our community in particular, there's a lot of overlapping service providers that just don't know, the right hand doesn't know what the left hand is doing. And so as we've built these relationships over the last 4 years with hospice providers and police, ambulance companies, primary care, behavioral health, housing, we've started to develop these processes and workflows to to send patients to the right care, but we still haven't had the right information systems. Rob and I talk about it as often you find these individuals, it's like a traffic accident. You know, there's bits and pieces and fragments of their story that you collect when you see them, but you can't put together that holistic picture in a 30-minute conversation. It's just not possible. So we really were looking for a solution that would allow us to better collect information so that we could see that traffic accident not in the rear 6 months, but see it in real time, see it as it was unfolding and be able to collect and put those pieces together, even though geographically we were in different agencies and part of different teams. And that's how we got connected with Rob and signed on to be part of this Health Commons project, is because we see that building this natural community of care that we were already doing, and I'm guessing a lot of folks in here have already been working towards, is now there's an organized framework and a technology that can underpin this and help make the operations run. So that's really our work in Puget Sound Fire and Valley Medical is really a similar concept focused on bringing together mobile resources in the community and connecting all these different siloed agencies. I will touch a little bit about the excitement of being able to work across geographies. One of the big advantages of the Medicaid transformation project and seeing these ACHs come to life is that we all want to work together. We don't want to reinvent the wheel in this side of Washington and then reinvent it over there. And having a Health Commons project participants across geographies, we've come together and said, we want to work together. We want to share ideas about what we're learning and share the costs of the system because there is a cost for putting this technology into practice. So we have an MOU, Memorandum of Understanding in place that we've actually put together across Olympic, Greater Columbia Community Health, Accountable Community Health, and then Puget Sound Fire and Valley Medical Center. So we're starting to get a group together to really share ideas and start building these ideas out.
I have a question. You have a unique challenge in South King County in that you've got 3 hospitals in the southern part of the county, all in different organizations, King County Public Hospital District 1, Multi-Care, and Catholic Health Initiatives. You've got 2 different fire agencies at least, BFR, PSR, PSFR. You've got layers of social service agencies. You've got a great food bank in Kent. You've got a massive one in Auburn. How many of those people aren't at the table yet, and how are you going to get them there?
Yeah, great question. Thanks for putting me on the spot.
Anytime.
Yeah, I think we have built this system, this health and social service system over time to address the individuals in need who are right in front of us, and we've done it with the best of intentions and with our hearts in the right place. What we haven't done is considered how to build a sustainable and connected system, and I think that's the challenge right now is how do we do that? And you know, King County Accountable Community of Health has a really tough challenge ahead of them, which you may have out here, which is just the number of stakeholders that are invested in this work is truly challenging. And having everyone sit at the table is what you would dream of, but you can't get work done when you start with everybody sitting at the table. And so what we've had to do is look at our community and the people and the processes that are already in place who we're working with. Who we already know the need is there and the value can be created, and start with those agencies and say, okay, here's 6 or so agencies that we work well with together, let's now take a deeper dive and really say what's the right framework, what are the right workflows, what's the right technology to make this into an efficient and effective system. But it's that in business school they would call it a minimum viable product, right? We want to see what that minimum viable natural community of care looks like for us, and that's really our first challenge.
I only ask because I used to practice there, and I'm trying to imagine how you hurt those cows.
Yeah, there's 30 fire departments in King County.
Yeah.
So it's a monumental challenge to envision how they could all work together, but it's possible.
Yeah.
Go.
I have a question. I think it's probably directed at you. So we were out with one of the practices that we're going to be working with, and they mentioned community paramedicine being reimbursable for not transporting a patient, but still doing the follow-up. Have y'all considered that, and what's your plans for that?
Yeah, so great question. So the question was about community paramedicine and the potential reimbursement. So, and I think this speaks, if we take this up a level, this is what everybody's asking about, right? Is how do you move to value-based payment given our current situation? What are the mechanisms, the financial incentives that are really going to sustain this work going forward? I think the problem isn't the lack of money, it's the lack of aligned money to get the outcomes that we want. And so, our sense has been to start with the natural community of care, figure out how to deliver the care and the services that are going to improve value, and then look at the financial incentives that can help reimburse that care. So that example of community paramedicine, I think it's the House Bill 1351, I think, is for treat and refer, treat and release for community paramedicine. That is a great example of an incentive system that is being built to help this natural community of care. So our goal would be to get the system up and running and then potentially pilot a test case with the healthcare authority once we have that to figure out how do you collect payments without standing up a billing system and all the administrative work that goes along with that.
Yeah, I kind of have a follow-up question.
Sure.
How do you picture the commons, the digital kind of software piece incorporating into that as well with the community paramedicine?
Yeah, so
Sorry.
Yeah, sure. So the question was, how do you picture the digital aspect of the Health Commons network interacting with the community paramedicine work that we're doing? So, in the modern service economy, what we've realized is that it's not enough to just deliver the service. We need a technology-enabled service. And so our initial approach when we met Rob was really figuring out how do we make this a technology-enabled service so we can easily coordinate care, it's easier on our providers, we can really figure out the impact, what are the outcomes of what we're doing, which is really challenging. So for us, the digital commons provides an opportunity to have that feedback loop, that e-referral feedback loop that we were talking about, which is so important for outcomes data. It has the opportunity for us to care coordinate and care communicate with partners when we're on the same live network, and potentially get reimbursement. So it has potential applications in a lot of grounds.
I'm going to add in real quickly we set up the commons to be technology agnostic. I don't work for any software companies or vendors that are trying to sell solutions. I work for the community. And so what we're doing is setting up more kind of group technology purchasing to make sure that once we understand what service types, what's the things that we need to get done information-wise, that we can do this in a coordinated way. It also saves a tremendous amount of time and expense on the vendor or supplier side, because I'm a technical person, so I speak their language very quickly. I just simplify a lot of the communication that goes back to the tech vendor. So we're able to now get a lot of work done digitally very quickly. So, and I love the comment earlier on direct secure messaging. Well, that's another type of technology you can add into this commons framework. So, but again, everything starts with the providers and the care services you want to provide. If we start technology first, we end up in the wrong place. So, and most of you that have consumed current digital tools have kind of figured it's like, wow, how did they come up with this particular design? But we really want to start with what are we trying to get done, and then walk our way backwards to the technology and make sure that we're getting you the information you need and have the information flow as quickly as possible.
Okay. Thank you.
So, are you guys done with your presentation? So we have time for Q&A now from the broad group. Jack?
Well, I just want to, and I was flipping through the slides as you were talking, and I think that your model is you've got a really great approach, and your ability to bring the community members together, both technologically and also in figuring out processes is well, it's going to play out well in all those communities. I do want to address a little bit the sustainability question.
Yeah.
And I saw the slide in the slide that draws a direct comparison of the financial piece pathways versus your model. And it's a little bit of apples and oranges.
Definitely.
And because the pathways piece includes not just the platform for communication, but it also includes validated, standardized interventions for each of the, whatever the health issues, housing, tobacco use, et cetera. And it's that last piece that has enabled across the country a variety of insurance plans to be able to pay for and sustain and support what that work is doing. So the technology and the setup and all of that is very important, but you're going to need to really look at how do you quantify and how do you standardize the work that's being done, and to really get that evidence-based stamp that Pathways has in order to be able to be sustainable going forward.
And in our health network, I could do another 20 minutes on KCHN. But the whole point of the network was, well, twofold. One, we knew we had to bring people together in a sustainable way, and in order to make it sustainable, we were going to have to collect our own data, and which is really what started to push. We were actually starting to try to set up, Steve Chrisman and Harry Kramer and I were trying to set up our own data structure before Rob came along. And I confess that I stole 10 weeks of an intern's life by making her learn to use Microsoft Access. And
Feeling guilty?
I remember learning Access during the first Washington State Diabetes Breakthrough Collaborative back in 1999, and I apologized to her when I said it hasn't gotten better.
So then you move forward.
Yeah.
You can only apologize so much for that. You're gonna move forward.
Yeah, but you're right, Jack. We do have to have that piece in place. So what we wanted to do was one of the advantages we have in Kittitas County is we don't have 3 hospital systems and 30 fire departments. We have 2 fire districts, 2 hospital districts, both of which have the same administration. We have 7 school districts, 1 university, and probably 4 other employers that employ more than 500 people in the county. So there are fewer moving pieces, and we're relatively geographically isolated. When I was first recruited to KVH, that was actually one of the draws, was that I was brought there to do systems innovation, and it's kind of a terrarium. I don't have to worry about people, if there's an accident on Valley Highway, East Valley Highway, and it's halfway between the drive-in and the south end of Kent, I don't have to worry about which fire agency is responding. But yeah, we're mindful of that, and that is, from our standpoint, that's the payoff of getting this done. It's facilitating communication and documentation. Yes?
So the question is, this is set up through, systems of care, right? Is that what I'm understanding? This is specifically for systems of care, organizations that deal with people only across the board. Is that what I'm understanding?
That's not our vision for where we want this to go.
So, what I wanted to ask is that doing outreach it's difficult to reach everyone. And being boots on the ground and doing outreach for homeless, mental health, co-occurring substance use disorder, physical health, all that. It's difficult for being one person with those boots on the ground and reaching everyone. If there was a way that they had a portal, an individual portal, to report their circumstances or give grievances about what is not happening for them so that need to be met, and given an opportunity to get feedback and direction with respect to resources available that they could reach out to. And this is something that I had to teach people how to use those resources, how to engage in those resources, and be successful in their own personal health, their own personal goals, by utilizing these resources. Being proactive in that, whatever I was teaching, they were teaching others. And so when word of mouth comes back and says, hey, I went to this portal and it had some of my information in there, and some of it wasn't correct, so it needed to be corrected, and I had to work with that. So my question is, if this is just for providers of care and not also the consumer, then you're not going to get a lot of that information. You're not going to know that they might be dealing with diabetes, but they're also caring for someone else, and their health is deteriorating because of the care for someone else.
So one of the things that we wrestled with was how open do you make it? And initially, not very. And that's a conscious decision because on the one hand, eventually we'd like to be able to have somebody make an online referral and say, I'm worried about my neighbor. We're also conscious of somebody going online and saying, I'm worried about my neighbor for reasons that are perhaps less than altruistic. Perhaps you're in a custody fight and you'd like to salt the fields. There's also the question of, the other question is what information can you get out and how tightly is that controlled? One of the things that we've been working with Rob on is having different windows into the data. So if we're making a referral to Hope Source for transportation, the data that they need to see on that individual is fairly limited. If we're trying to get information back to their primary care provider at Community Health of Central Washington, they need a more detailed, less restricted view. But eventually, we do want those portals to be as broad as possible. One of the people in the community that we haven't figured out how to utilize more appropriately and wants to be involved is the Ellensburg librarian. Because every morning when she opens her doors, there are 8 guys that come in, and she can see who's not walking right today.
What I can tell you is that there's very few technological limits to what, whether it's an individual patient portal and so forth. There's lots and lots of different ways we can solve those issues. But as Dr. Martin said, it really kind of starts with, the experts internally and getting comfortable with what makes sense. And I forwarded to Wes last night some documents that we've been working on at Olympic about, what data policies. And so it's this is a community system. So you got to be very, very clear about who has access rights to what information and how to do it. So it can't just roam in the wild quite yet. It has to be done in a very, very thoughtful, systematic way. As much as I would like to see it, just go wild, but that's just not the way this is going to end up rolling out. It's got to be one of my colleagues at Healthcare Authority calls business moves at the speed of trust. So for a network like this, if it goes too far, too fast in too many different directions, people lose trust and that's it, it's over. So we got to do it in a very, very systematic way.
So I wanted to bring back a little bit of a historical perspective to our work. As you know, last year, the board and actually the leadership council came together. We made a conscious decision not to move into what's called Project 2B, which is around care coordination. And the primary initiative under care coordination was the Pathways Community Hub, which Jack talked about. The Pathways Hub model is a very robust model. It is evidence-based. There's an accreditation body that goes along with it. There's formalized training that goes along with it. Very comprehensive, very robust. It is very expensive. In our research around the model, we found it to be somewhat inflexible. And we didn't necessarily see that the pathways that they had outlined were consistent with the other project areas that we wanted to succeed at. So with that, and for some other reasons, Health Management Associates, HMA, a consultant that came in and advised us, also recommended the same decision. We made a conscious effort not to go with that care coordination project area. However, we recognize that care coordination is absolutely fundamental to the work that we were doing. In the patient-centered medical home, it's a key component to that particular model. And so when our navigators go out and meet with those practices, this is one of the functional areas that we emphasize. But it's also important from the system level. So we were looking for a model to fulfill our pledge towards care coordination, hearing Elia, and subsequent to that, talking with Rob, we became very comfortable with this model. I have to tell you, this really is the right approach. Simply taking a product and trying to a fixed product that is somewhat inflexible and trying to overlay it on the system isn't necessarily always the right way to carry about good transformation of care. The better approach is to bring the stakeholders together, as happened in Puget Sound and is happening now in Ellensburg, which may potentially happen in other areas in our GCACH, is to bring the stakeholders together, do a gap analysis, understand where are our patients falling through the cracks, and which providers will touch the patients to help prevent that. And then once we agree upon that, then spend time creating, we can call this a number of different things, workflow, pathways, use cases, ironing that out. And this is not a simple process. And what Rob has talked about, this can go through iteration after iteration after iteration. Part of the reason for that is that individuals' expectations about how that process flows can be different, and they don't always recognize that. But once they come together as a group and they go through that iterative process, they understand that how people perceive that process can be different. Going through that process helps iron that out, and it helps come up with a unified process everybody agrees to the point where they're even using common language about that. Once you've done that, then it's time for the IT integration, not the other way around. So I firmly believe in this process. We've seen great results, and we hope to push this further.
More questions? Our speakers. I just want to follow on what Wes was saying, which is that to the extent that what we're doing is novel, the probability of us finding an existing product that meets the needs is essentially zero.
So I guess, and I'm still very much great about what it is here. So I think I've got more questions than anything. But going back to what your comments just were, is where we left off in this conversation months ago was, one of the things that I think a lot of people were talking about was there currently is a lot of care coordination going on.
Sure.
However, and you just said this, is that not all of us do it the same way. One of the things I thought that we were hoping to get to was a standard, at least at the community level, so that we all had a common understanding and a community standard of what care coordination was.
right now, we have, 5 health plans and aging and long-term care who all ask us to do care coordination in a different model. And what we were hoping to do was to get some agreement among the MCOs and aging and long-term care for those of us that work with all of them, so that we had one common understanding. In terms of care coordination, the community health centers, as an example, starting next year, have to report to the Bureau of Primary Health Care on referral management and our success in terms of how we close the loop. This is a brand new standard. So if we add another registry, which is what I'm picturing this to be, some form of registry, we're logging, we're going to be using, 6, maybe 7 different portals or registries to communicate a different set of standards. So, I'm still hopeful that at some point down the way, we're going to have this conversation again about how we're going to maybe narrow down at least some the standards that we're expected to live by, because we all want to get there to be able to share this information with each other, to be able to make those handoffs more efficient and more meaningful. And I haven't even said anything about meaningful use, which is the other piece of this.
Right.
But we have to get there before we can talk about another platform that we're going to be using. And how has that worked, and how have, in the other communities, how bought into are the primary care providers? Because they also have to deal with their own EMRs and put it into the registry.
And in this particular case, we do actually fully integrate with the EMR. Sorry. The way this technology works, we do fully integrate with the EMRs. So the use case that we developed in Olympic Peninsula, the primary care doc, the one that's actually the prescriber for substance use treatment, is actually placing an order through their EMR that sends a message out. They happen to have an internal coordinator that actually will coordinate care with other agencies. And so the order just travels through the EMR, we pick it up in the referral network, and then the navigator at the FQHC sends it off and then does the work. So for the provider, all they do is they send an order out and then they get a message back. So the provider doesn't have to get in the actual subportal underneath it. It truly is a communication system between folks that are responsible for doing the coordination.
The people that Kevin described, of the people that you're targeting in here, sound an awful lot like the health home patients. So I guess, Corey, I don't know if you guys are involved in this, something citizen.
Our offices,
So do you find a lot of crossover in that, and how does that work? Again, I'm just thinking about duplication. I'm just asking if it's another platform on top of the health home.
Not as much, because the qualification for health home is based on PRISM score, which is based on hospital utilization. And the people that are failing in the community often aren't in the hospital. And that's actually been one of our struggles, is the best indicator that we have right now is the EMS District 1 and District 2 blotters, and how many runs are we making without transporting. In other words, how many times we have people that dial 911. The individual that now has a guardian, when I first came on the A-team, was calling Ellensburg Police and KVFR to get groceries. Horrible waste of resources, glaring need that doesn't come to anybody's attention. So we're working to, actually, one of the things we're building into the intake tool in this engine is the AAFP's screener for social determinants. But we're still looking for a good way to identify people proactively. The PRISM is by definition retroactive and reactive. So retrospective and reactive, there we go. So how do you identify folks with need before they fail, rather than the ones who just fail, who are showing up in the emergency room in the hospital? The people, actually the overlap that we have with health homes is periodically the hospital will get a order where one of the assisted livings or the family will decide we can't deal with this anymore, and they will drop them off in our emergency bay with a suitcase. And the referral source will refuse to take them back. Our record is 262 days to find placement. So there is overlap, but again, one of the very humbling things I think for all of us in our network has been the realization, and it's the fragmentation you're alluding to, that no one of us has either the perspective or the tools to solve all of the need. And we have to work together.
And it's fun. Because the reality is, if you look at the evidence for care coordination programs, it's all over the map. And that reason is that care coordination programs are all over the map. People have different definitions and different ways of implementing them. If you're talking about sustainability, and you've got a spectrum from a program that's got extreme flexibility and a program that's got extreme rigor. And the people who provide services like it at this end. They want to be able to address their local needs, their local circumstances, their local population. For it like it is this end. That they know exactly what they're getting, and they know exactly that these steps are going to produce these outcomes. And your challenge is finding somewhere in the middle, something that's going to have enough commonality, and you're going to be reproducible enough that you can go to the payers and say, we know that if we do X, Y, and Z, then you'll get these outcomes. And that's what I think you can learn from the pathways, not the tool itself, not the model itself, but how did they do that? How did they get that level of evidence? What steps did they take? To learn from the how do you get to the point where people are willing to pay for something so that you are not at the end of the ACH funding and you've got nowhere to go?
That's a great point. And that actually is kind of the model we're thinking about. So one of the interventions that we want that was missing from the pathways that we would like to formalize is a referral for advanced care planning, and potentially a referral for hospice. We know that there's great data for both of those saying that will pay dividends for the payer, but it's work that is largely done for free.
Susan? I have a question somewhat more related to implementation of this kind of a product within a community. Have you thought through, or from your experience, how you help a community to prioritize on phases? Like, not everybody can be at the table at that first stage, yet we tend to lean towards what we're most comfortable with, which is medical, oriented, and leaving out the social determinants. Transportation is a huge connector, if you want to continue to use your analogy. But have you thought through models or ways to help communities do the implementation in a way that keeps us forward thinking instead of comfort?
Yeah, that's great.
Could you repeat the question just for?
Yeah, I think given the experience of providers in the clinical aspects of this work, oftentimes the social issues, transportation, access to food, basic housing or shelter, can get overlooked in the medical evaluation. And so how do you ensure that you're bringing in the social determinants of health and the social information into the actual care planning process? I was going to say, Adam and I were talking about that very issue on the way over today, but, and I would argue it's up to the communities to figure out what they want to do, but, transportation is a basic issue. I can't tell you, I've done a lot of qualitative surveying of providers and so forth, and I can't tell you how many examples came up of just saying, well, we were building a relationship with this individual and so forth, and they just stopped showing up. And then, later on, that, somebody figured out it was a transportation issue. And the state of Washington actually has a transportation subsidy program, and I was talking to Bob Crimson about it, and he's like going, nobody knows how to tap into it. So again, we have all these Lego blocks that haven't been assembled in the right order. And part of that is the information flow. And so, there's even healthcare authorities now talking about, 80% of an individual's health is related to their social issues and 20% to the clinical care. So you would think that we should be prioritizing those issues and how to coordinate those services better. Personally would love to focus on that, but I got to default to where the community is and what they want to do, because at the end of the day, it is based on, these groups these natural communities of care coming together and saying, we commit to do these services, and then we're going to use this information to make the care work. So, but Adam, I don't know if you want to add a little bit on, because he's in the transportation business too, in the fire department. So
I can give you an example where the conversation has gone recently in South King County. We have a partnership with a program called REACH, which is part of Evergreen Treatment Services, and they provide street-based case management for homeless and unstably housed individuals. And they're really that relationship expert, engaging clients in care in where they live. And so what we've talked about is maybe focusing our natural community of care for the first year on the care type of homeless and unstably housed, and having that REACH person be that customer or that client contact, and then building the services around that, which would include housing providers, transportation, food, as well as kind of the health system and EMS making referrals to REACH. So I think depending on what care type and population that you want to focus on in your natural community of care, you can see how those social determinants of health could be very front and center.
So it sounds like taking a patient population or a group of people who are strong in need and social determinants kinds of issues. Is that what you've done versus taking an organization or a couple of strong, well-funded organizations?
Well, each community, I think, is working on this in different ways. I mean, we started Puget Sound Fire and our FD Cares program with Valley were the initial supporters of this project. So you could say that those are two strong, pretty medically based organizations that said, hey, we want to partake in this. But as we think about who is the population we want to serve in our community and design these new care teams and services to work together in this natural community of care, in Seattle Fire, 22% of their EMS calls are for homeless related issues. So that type of need is really impacting our service delivery, and so it makes sense for us to say, hey, how can we better serve this population? But we're doing it as, similar to how you're doing it in Kittitas, is saying who are the organizations that touch these patients that we can work together.
Corey? This just comes to mind when we're talking about communicating between agencies, social service agencies versus the medical field and that kind of communication. And I think this just goes through my mind, is we are piloting something with Memorial right now. We've been around and we're a social service agency that we're not tied to any service, but we help navigate people through what's available in the community. And the hospital staff knows us. We've tried to get the word out, but you don't get the referrals. But now we're in their system where a doc or a nurse can click a button and the referral comes to us. Now that we're recognized just like the heart specialist, just like the lab, when we're in that system, which I can't remember what it's called, but we're in that system, so now we get referrals because we're in their world. So that's the linkage for social services. Because now it's amazing that we can go in and talk to those people actually while they're in the hospital and start helping them navigate community-based services. But the real resource has always been there, it's just that we haven't needed the button to push or on the script to say right. That's common to them.
Yes.
Yeah, great point.
Carol,
So,
we're going to have to wrap this up.
all right.
Yeah.
So Jack had talked about the pathways hub model, which I think Kittitas was considering, to begin with, and I think you brought up some good points, Kevin. But then who is ultimately in charge? Is it the primary care physician? Because with the pathways hub, it's the care coordinator that coordinates all of these different services. And so there's an accountability there. What is the accountability in the system?
Well, at least the way we've envisioned it, and this is what we're kind of working through with each community, is that when you form a national community of care, you're actually going to have somebody who's at the hub. So it is very similar to Pathways Hub model. As a matter of fact, the Pathways Hub model is completely compatible with it. So we're just providing, more technology and more infrastructure for making sure information can flow. And that was one of the limitations of the Pathway Hub model. So if you wanted to use, I think, as you were saying earlier, if you want to use more of those evidence-based tools out of Pathways Hub, and you want them now modeled into a data flow, we can do that. It's so the technology we use is very flexible that way. And I think Kevin can attest that, we want this information, and then I take that and then we lay it out schematically, and we make sure that we can deliver that. And we want to make sure it's that same experience where it's like you're in the EMR and it's like order, as opposed to ordering lab, I'm ordering behavioral health, or I'm ordering transportation. These are just kind of orders. The difference we have with our technology is we're actually tracking the states and the statuses of those referrals. So that's a little bit different than what the current systems have today, because they're just sending a message saying, do this, but we actually need to know what happened.
Kevin, hang on just a second. Rob, before you go, I know we're kind of short on time here, and I want to get to your presentation. Kevin, can you speak just for a few minutes or a couple minutes about 42 CFR Part 2?
Oh boy, that's not a 2-minute conversation.
I also want to answer Carol.
Okay.
The answer to the question about accountability is the reason the term PCMH was coined. It's patient-centered, and that's where the accountability ultimately lies.
That's great. On 42 CFR, there's no short one on that one, unfortunately. What I can tell you from an information technology perspective, there was a rule change earlier this year with 42 CFR, which allows an individual to consent to a health information exchange. And those parties that are on the health information exchange, which are related services, you can consent once, and that information can be shared. In our version, that is a natural community of care. These are we're now taking these unrelated disparate providers, making them related, and allowing them to share within that care network. So there are very complicated, the prior ruling on 42 CFR, I can just tell you from a software and a logic perspective, was really difficult to figure out, just because there were some very, very specific tight access control types of issues, which I won't worry you with the details on. So the new ruling earlier this year, people are now starting to kind of rethink through how that software should be set up and worked. And there is a consent management tool that I know the state is really interested in, and that's the kind of thing that we would also try to incorporate in. But you still got to collect the consent, and the consent has to be related to this particular network of care providers, and then the sharing of information. So hopefully that was the
Hey, Rob.
Yes.
Rob, can I add something about this? This is Elia from Olympic Community Health. We're getting a lawyer who specializes in 42 CFR to pressure test the health commons, and be happy to share their ruling and findings with Greater Columbia as well. And you too, Adam.
Please, thank you.
Yeah, and and the nice part about where Elia and the Olympic team is, we've actually, the workflows that we've set up there, we've actually taken this all the way to the production level. So if they did want to start exchanging patient health information, we could do that today. The issue has to do with, the governance issues and stuff like that. So we're, Elia and team in Olympic are breaking a lot of new ground up there, and I know they're going to happily share that information with everybody.
Thank you. Any final questions for Rob and Adam?
I just have one more question. So what's to prevent overlap, like you have a referral come in from one prospective primary care physician, and then but they're seeing another, and then they both say this person needs transportation. What stops that?
So there's a techie answer underneath that. So each individual has a unique record. So in today's world in healthcare, there's no such thing as a health record. There's health records.
Right.
And then they're spread out in all these different places. So what the Commons is doing, and again, I won't worry with all the details behind this, but we're really working through what that unique record should end up looking like, and then how do we connect those records into the other systems. So if in fact the same individual is now accessing from multiple points, we're going to actually know something about that individual. So to make sure we don't get those collisions. In other industries, this is done every day routinely. It just hasn't been applied into healthcare yet.
Thank you.
All right, can we give our two presenters from List of the Mountains? You're not taking on right away, are you?
No, I think actually Adam.
All right, so after for 3 minutes, if you guys have more questions of these two, then fire away. But we want to give one of our own here, Dr. Kevin Martin, an opportunity to talk what's happened in transition care in his community. And so thank you, Kevin, for putting together the presentation. I saw you got 17 slides, so you'll make it, right?
Yeah, exactly. I don't plan on spending more than 4 or 5 minutes per slide.
Can we have a short break?
Can we reconvene at 5 till?
Yeah, it has to be real short because we want to give Kevin time.
2 minutes a slide I can do.
Yeah, okay. Very interesting. So, and wait this stuff. So, Carol?
I have great news for you about the standardization of There was a Washington State PCMH summit that had 156 meetings. 15 providers, 15 from major payers, and 50 from employers ranging from the state and the university to declining population of Oklahoma. And they met at the Seattle Center and standardized what state and what came and started working on. State of that meeting is October 15th, 2009. Well, because when they came up with that was Joe Gibbs started the morning session was looking for and everybody was looking out. The afternoon session was having a budget. And we just started the conversation by saying, right now, primary care costs $25 per member a month. Well, thanks, Joe. We can all go home now.
So that's where it stops, except in this new environment when we all